The purpose of doing tests is not only to make a diagnosis, but to decide whether treatment is appropriate or whether you need further help from other professionals. Maybe you're wanting some investigations like imaging. Maybe you're wanting to write a referral for some tests, or maybe cortisone injection. Or maybe you're wanting or decided that you need to collaborate with other professionals. Maybe you need some help taping, or maybe you need some help from acupuncture or cupping or a trigger point therapist. So when you're doing the test, you're starting to think not only about the diagnosis, but whether it's appropriate to collaborate or refer on. So for Addison's test for thoracic outlet syndrome, we're testing that integrity of the neurovascular bundle from the subclavian underneath and between the collarbone and the first rib. We're going to take the radial pulse. We're going to abduct and externally rotate the arm. And we're going to feel, does that pulse disappear? Can you turn your head towards me, Demi? Then tip your head back slightly. Then open your mouth wide and imagine you're having a big deep breath and a yawn. And here we're introducing the scalenes to see if the scalenes, if they're tight, are they interfering with that neurovascular bundle? And relax. And if there is an absence of that radial pulse, we have a positive Addison's test, which could indicate many things, one of them being tight scalenes, one of them being a extracervical rib, and other pathology, maybe Pancoast tumour. But it is a topic in itself, but those are a few things that it could suggest. The next test we're going to do is an apprehension test for suspected dislocation or laxity. So I'm going to take hold of the patient or your client's wrist. I'm going to hold the head of the humerus. Sometimes I even put pressure at the back. We're going to externally rotate and abduct, and then we're just going to take this beyond that 90 degrees horizontal flexion movement and just apply a little bit of pressure from the back, not too much, this is a test, and watching the patient's face for a feeling that something is going to go. That's the apprehension. If somebody is prone to subluxing or any laxity issue, they're not going to like you doing that. Probably when you get to about here, they're going to feel like something's just about to go or pop. And that's the apprehension test. The Gerber's liftoff test tests the subscapularis for weakness and for tears. And what we do is we ask the patient, or we get the patient to internally rotate, put the back of their hand on their back, and then ask them to move their hand away from the back. Can you move your hand away? And then relax. And then you can test the strength of the subscap as well by asking them to press against your hand. If you press against me and relax, a positive test is pain in the shoulder. So for the prayer test, we're testing the integrity of the sternoclavicular joint. So I'm going to use just 2 fingers on the superior aspect of the sternoclavicular joint. And then I'm just going to ask Danny to put his hands together in a prayer sign and just press slightly and raise. And my fingers should glide inferiorly. And a positive test is if they don't, or if there's any discomfort. And that's the prayer sign. Now, here's a little sneaky tip that my lovely orthopedic surgeon friend shared with me. When you're doing orthopedic tests for the shoulder, why don't you just do this one first, because it'll eliminate it. Frozen shoulder test first. So, elbows into the side and externally rotate for me, Danny. And relax. And then I'm going to do it passively. I'm going to take over. We're going to externally rotate and we're going to compare on the other side. And that's it. Boom, done. If there's a difference, there's a possibility of a frozen shoulder. Different phases of frozen shoulder are different phases of the freeze. So always check and always do that one, because symptoms can change and you may be looking at a frozen shoulder at some point during your assessment and your treatment. So keep checking each session, external rotation. And then another one that you can get out of the way quickly is the shrug against resistance test. Testing the trapezius and the acromioclavicular. So Danny, if you can just shrug your shoulders up for me, against me, and relax. If they've got a problem with the trapezius that would provoke pain, and also if there's a problem with the acromioclavicular joint, like a ligament tear, you're going to provoke pain. So that's that one done as well. The OBrien's test. You have your patient sitting or standing, and the patient horizontally flexes the arm. Nice straight arm for me. Then we introduce adduction about 10-15 degrees, and then we internally rotate at that 90-degree angle, and then we ask the patient to resist our pressure and see if there's any pain. Any pain, Danny? And then do the same thing. Any pain, Danny? Against resistance. This test is used to diagnose acromioclavicular problems and sometimes slap lesions. Now the belly test, I prefer the belly test, again isolating the subscapularis muscle for a tear or weakness. And all I'm going to ask Danny to do is to put his hand between my hand and his belly and press against me here. And I prefer this test because there's none of this internal rotation, which can actually be challenging for somebody who's already got shoulder pain. And maybe if they've got an AC joint issue, it's quite uncomfortable for some people to take their arm behind the back. Something that might help you when you're evaluating the rotator cuff, and particularly that scapular thoracic rhythm and motion, if you ask a patient who's got pain somewhere between 80 and 120 degrees, if you ask them to abduct their arm to the point where they are experiencing pain, from there maybe to there, if you get them to do that, experience their pain, and then just try and see what happens when you apply pressure to the shoulder blade, and try that now, Danny, and ask them, is that pain less? And a lot of the time they'll say, yeah, that's less. And that's because, remember, those scapular movements, the muscles that control the scapula, if you anchor it down at the bottom, it may relieve their pain. If you push it forward and anchor it onto the thoracic spine, it may give pain relief during abduction. And then you know which muscles to work on. So in this particular instance, Danny was experiencing pain between 80 and 120, yet when I applied pressure to the inferior angle of the shoulder blade and kept that anchored, carry on for me, Danny, there was no pain. So what does that suggest to you? Perhaps working serratus anterior and those lower traps.